Okay, so we are in the midst of a series that we are calling Dancing with Data, something that Genetic Alliance has decided to do as a result of some of the requests from the advocacy community. We're asking all of you as you enter to put your full name and the name of your institution after your name on your little screen. To do that, I'm going to give just a moment of education around that because I think it's important in a lot of places you go. If you click on your own square, the little three dots in the upper right-hand corner, you can slide to a place where it says rename and put after your name, the name of your organization, because then it's there and it won't get disappeared in the chat. Okay, so in this series, we are attempting to give as much background and education to advocacy leaders around data, which is, the big thing we all know now. It wasn't as cool when and I should say I'm Sharon Terry, the CEO of Genetic Alliance, started 26 years ago when my kids were diagnosed with PXE. I created the first ever lay-led registry at a time when data was just considered a side thing. It wasn't really all that important. I thought, and I think that's borne out, that it was going to be very important and one of the most important things as advocacy groups that we could do. We have a lot of partners in that, and some of you are here with us on the screen because we've expanded over our years as Genetic Alliance to communities, to public institutions and so forth, and certainly academic centers, partnering with you all so that we're all working together for people at the center. And Genetic Alliance runs a registry platform that we've run for 26 years. And we have our own IRB. We have our own biobank for the last 20 years or so. And we have some other tools, as you're well aware. So I invited Abel, and Abel, I'm not going to give you a formal introduction the formal way, except to say that I worked with Abel during my years at PCORNet, so for about 5 years, and before in a variety of ways that we intersected on NIH grants and various committees and so forth. And I've always been impressed with your capacity, Abel, to explain data in a way that people can understand, and also to get that it's ultimately in service of our all striving to alleviate suffering in our communities. And so without further ado, I'm going to turn it over to you. This is recorded. We will have this archived, and you can listen to it at any time for those of you that are worried you can't take notes fast enough or something. So Abel.
Thank you, Sharon. And I have to say that I'm very excited to be here today. I really enjoy, I think, these opportunities. I admire the work that, Sharon, that you've done over the years. I think you are going to where the puck is going and not looking back, which I think is admirable. And yeah, I'm absolutely committed to this, to patient-centeredness. I think you've been a great help for my patients. I know. I thank you for, I think, responding to some of the people I've sent your way. And so again, admirable work. I think this might be a little bit easier and better as a discussion, if possible. And I know, Sharon, we talked about that a little bit. I did prepare just a handful of slides. And if you don't mind, I will put up one only because I think it will illustrate a little bit about, can you see this one slide? It's
yes. Yep.
Okay. All right. So all right, so this slide, this single slide, I think captures why I think the work that you do is where the puck is going and why it's so important. And I've always loved this slide. It's from a New England Journal article from 2001 about the ecology of care. And if you look at this slide, this tells you all you need to know about why patient-centeredness matters. So this was done using administrative data. And what they did is they tried to figure out, like, where do people go for their care? And if you look at this, over the course of a month, out of 1,000 people, like, how many actually show up at a place like Northwestern, where I work, at an academic medical center? I'm a primary care physician. I see folks. Less than 1. So not even a percent. Like, I think that math is 0.1%. So under 0.1% ever show up. Yet where do you think most of the research is done that we base a lot of our medical decisions are based on? It's based out of that tiny little population of people that happen to show up, get recruited to an AMC. So how representative do we think that is? Well, if I'm looking at the numbers, That's not great. Now, if you look at anybody who ever received care ever over the course of a month, maybe at most 20, 22%, something like that, will ever show up for any care. So even the chance to be included, and just to be clear, most primary care offices, many of them are not within AMCs. They might be a family practitioner in a community somewhere. Is that data being included in research? I'd argue it's not. That means the vast majority of people that are out there, that are truly representative of who has what and how they're being affected, are not currently being included in research today. And that's why you are representing where the puck is going. We have got to do better. We can't just be sitting in that tiny little bottom right corner. We've got to be moving out to where people are, meet them where they live, like understand their circumstances, what their needs, their wants are. If we don't do that, we're missing out on the vast majority of what matters to patients today. So let me stop there for a second, because I wanted to just frame this and see if anyone had any comments or thoughts about this. And again, like I said, I'm going to stop a lot because I do think that this will be much better as a dynamic discussion.
Fabulous. Thanks, Abel. So as Abel said, this is a discussion and there is no dumb question, because as I pose some of the questions I've gotten from advocates to Abel, he said, my students and colleagues have the same questions. So feel free to ask anything at all, because it will be helpful to everybody. So I'm going to just throw it open and see where you guys are at.
And I do have some other things to accentuate if there is quiet moments, but I will share one other thing just related to that. This was actually an interesting study. I think it was done in Europe, in Spain, and they looked to compare, like if you look at electronic health records, where we do a lot of research, I do a lot of research there, versus what people self-report, and then try to figure out how well do they correlate. Well, not surprisingly, the things that show up in electronic health records that we use for research are different than what patients fill out in surveys, right? Because patients have symptoms that concern them when they go into clinic. I mean, I have like 10 minutes, 15 minutes with a patient. The only thing I'm going to document are the things that rose to the level that either I can do something about, which is often the case, or that was of significant impact, or I just had time for. And so things that are like diagnosable conditions, diabetes, hypertension, where you have a number, those are going to show up. But things that are symptom-based, patient-reported things, they don't always show up. If I had a rash, or if I have, some issue with my back, or concerns about my stresses in my life, they're not going to show up. But they're oftentimes confounders that drive the underpinning conditions that you have or make them worse. And so that's, again, the point behind this slide and the last slide is that we're really missing so much. And so you have got to reach out and engage people, or you're missing the full story of what's driving health. And again, that's where I admire the work that you're doing, because I think it's crucial. Some questions.
So the question from Rick, to ask you to comment on the work coming out of PCORI. And Rick, do you want to, there's a lot of work coming out of PCORI. Do you want to pinpoint that in any other way?
Yeah, this is Rick Rader. I'm a council member of the National Council on Disabilities in Washington, and also the editor-in-chief of Exceptional Parent Magazine. And I also do research for PCORI, which is the Patient-Centered Outcomes Research Institute. And I wanted to know whether or not you feel the research coming out of PCORI is more substantial than what we have with just less than one person out of 1,000 showing up at an academic medical center.
Well, this is recorded, but I'll be careful. I'm in a bit of an awkward spot, because we were until recently a part of PCORNet, but recently we also heard that we were not selected for going for phase 3. Now I feel like I'm joining good company, though.
You are.
So I knew sure understand that. So I don't know how to say this in a way that's not going to get me in trouble, but I'll just put on a positive side. In Capricorn, in our network, we've always been committed to patient-centeredness. And I just came off a call with our patient community advisory committee, and we talked about the situation we're in. And while our merit review score was excellent, we had a 26, it was excellent and outscored others. I don't think that we were aligned necessarily with some of the direction that the network had been going, which was, I think, more focused on some of the NIH-sponsored clinical trials or pharma trials, et cetera. And we had said something to that effect. But we have to stay true to our constituents. We serve a group of people in Chicago who matter to us, even if they sometimes, I feel like sometimes what we do locally doesn't count somehow. But but that's just PCORnet. Now, PCORI itself, I do think a differentiator should be the patient centers. It's right there in the name. And I know there are excellent examples of people, researchers and patient groups, including some in Chicago, that have done great patient-centered research. As an example, we have a patient who is a transplant recipient who himself is driving a research study within Capricorn. So he's trying to understand sort of the pros and cons of different ways of doing transplants. And that should be what we're pushing more. It shouldn't be a network of AMCs driving AMC-led research. That gets us back in that bottom right corner. Like, what was the point? Then, so I guess to me, there are great examples, but I think we got to do a lot better. We have got to do a lot better, and we're going to keep saying that message regardless of what happens. We're gonna speak that fact.
Yeah, thanks, Abel. And Rick, maybe I'll add that I think PCORI has struggled to be people-centered. I'd even love if they got rid of the word patient, which they never will. And the gravitational pull is toward where is the funding, and it's NIH because it's the biggest elephant in any room, and NIH is investigator-initiated, academic medical center-initiated research. So we continue to struggle, as does Abel and others who have left PCORnet, and maybe we should make a different net and continue to work together, which we do informally, but yeah.
I would love that, Sharon. I think that there's a tremendous amount of energy and opportunity and activated individuals who would really, I think, appreciate it.
Yeah, good. Okay, thank you. I think, John, did you unmute and had a question? Or maybe it was Michael. Michael, sorry, yes.
Yeah, the first slide I thought was really interesting. What, at the bottom, did it say what year that was coming from?
It was 2001. Yeah, and so there actually this was replicated recently. I think it was done again in I forget, not that long ago, because my memory isn't that good, so it couldn't have been that long ago. So like a couple of years. And the findings were similar. I think the number instead of 217, it was like 22 point something, 200 and something.
Yeah,
the numbers really stayed pretty similar. And one of our students actually did a recent version of this too, which we never published, and we should have, which looked at of the 1,000 people, how many had data in electronic health records? In other words, easily gotten at. And not surprisingly, it's when your denominator is in the single digits, then so is your EHR coverage. Oftentimes is quite low. So again, we had a meeting this morning with a former patient-powered research network, Mark Pletcher, who's doing great stuff, and really exciting. I mean, how do you again reach out through mobile devices and to people where they are? And so we're speaking of working together with former members, like we're working with them now, and like I said, there's a large body of committed investigators who really want to get into that. To me, it's obvious. Like, if I'm like going to be digging for opportunities, and I look at this map and I say, well, I can either go for this tiny bottom right corner, or I can go for this whole space. It seems pretty obvious you want to be in the big space, but
Got it. Thanks.
Yeah, sure. And sure, if it's helpful, you did prompt me with a few questions. I'm happy to go and talk a little bit about those if those will sort of keep the things moving.
Sure.
So I just wanted to show one thing. This is when we think about population health. Again, there are some. This is EHR data limitations not just in that little bottom corner, but if you look at the nature of how people seek care, who seeks care, like this was Chicago again, you know, in that lower bucket, comparing the data in the EHR versus census for that same age group, a lot of young males don't come in for care. So if you're interested in a disease that's focused on a particular population, you have to recognize again that there's additional limitations oftentimes with the data that we're using for research. And then I also wanted to put in a few more plugs. Sharon asked the question, like, as we do research with patients, I think there's a question sometimes about what's this about data standards and that kind of stuff. And I am a person who loves data standards. I think it makes the world go round. But this is just, so I just want to share a few practical examples and tie back to healthcare. When we do research, again, we know we're limited in the population, but we're also limited because a lot of data out there is non-standard. And why is that important? Well, this is a map that shows all the different gauges, you know, the train width gauges across the world. And if you're moving, in this case, you know, goods on trains, if you come to a place where there's like a different track, you're stuck. You got to transfer all that stuff over to another train on this other track. And what we see is across the world, there's still a lot of non-standardization in train gauge. And this is, I think, a similar idea or problem that we have in healthcare. So this use of different types of data and different standardization of data. You guys all remember VHS and Betamax? Again, the standards problem, you know, had different devices and they're not intercompatible. And in healthcare, just to point out that when we're capturing information, whether it be from a patient or from an EHR, it still is really important for us to adhere as much as possible, if we're going to make the findings generalizable or comparable, to try to use data standards as much as possible. This is just an example of a simple idea. Like, you know, hemoglobin is a measure about whether the person might be anemic or not, you know, so what your blood counts are. And this is from a tool that's used to identify the best sort of code for a particular data element, in this case, a lab test of hemoglobin. We can see that for hemoglobin, there's like a bazillion, there's a lot, this list goes on and on, of different types of ways of defining hemoglobin. And so unless you know specifically the type of test that you want, the specific measure that you want, you know, it's going to be tricky then to say, I got hemoglobin from this institution or from this patient, and then be able to merge them together so you can then do an analysis on that larger pool of information. And so this idea of data standardization is also absolutely crucial for research, whether it's person-centered or not. You still can't get away from adhering to data standards. And so I encourage folks, if you are planning a project, to, you know, don't throw everything out, but do bring forward some of the principles we learned from other types of research, so that again, your findings are generalizable and interoperable and compatible. So questions about that?
Yeah, so from your point of view in your organization, either already capturing data or not, what questions do you have about these kind of general concepts that I keep hearing in this community over and over, and thought it would be good for Abel to address? And I think he just gave us some good fodder for thought there. So thoughts, questions?
Or maybe it might be helpful if there are folks who have particular products that you're embarking on or starting upon, if maybe people could even share a little bit about the nature of their project. And again, we could use that as a straw man to sort of carry forward some of these data principles.
So, hello, this is John. I have some maybe not well-formulated questions, but rather maybe some curiosities.
Yeah.
That doesn't sound horrid, but you get the idea. So
it's a friendly crowd, I think. So.
So I started to, I had the opportunity to meet some researchers who work in our disease area, in the disease area that I represent, which is multiple endocrine neoplasia. In particular, this was a person working in multiple endocrine neoplasia type 1. And talking with that person, I guess I think I didn't get it. And that's kind of why one of the reasons why I'm here at this meeting today, and just to learn a little bit more. And it was a lot about data standards, and they described just how important they were and how that hard to come by they were. And so in order to, so the long-term concept would be, say, like a clinical database, if you will, a patient registry that included clinical outputs and also probably data as well.
Right.
But even just clinical outputs, something. And I was just surprised at how long it took to get that together. And this is ultimately, this is so you can agglomerate across institutions, because in a rare disease, often you need everybody working together to get statistically meaningful numbers. So I kind of, maybe you could speak to that. I think you started to get at it, but, and then furthermore, is there any way to make that go faster? Like,
right. No,
really months and months and months or years or what?
Well, I don't know. The last question, the hardest. so because this is hard work. I think people sometimes think that data work is like, oh, we just pull the data and we're done, and analyze it, we're done. It turns out for a lot of I can explain some of the problems with that. First of all, the idea is right. For rare conditions, oftentimes you do have to pool across multiple institutions to get the numbers you need, right? I mean, that's actually, they're rare. But rare conditions, there's some pluses and minuses to them. On the one hand, rare conditions have oftentimes very activated patients who care a lot about their particular condition. And because they want to benefit other people, they're willing to share their information. So right there, that's a real benefit. But rare conditions oftentimes suffer from not having like good ways of defining the condition. So now there's some conditions will have like a very clear diagnosis code. But even those may not be perfect. So maybe it's not specific enough for that particular rare condition. And so then you have to go and find other ways. Now with multiple endocrine neoplasias, you have a combination of multiple different types of affected conditions. Well, how will you define each of those individual conditions? Will you define it using a diagnosis code where it exists? Will you define it using a set of laboratory tests, like maybe a TSH or some other laboratory test? But each of those different little considerations, you have to come up with a consistent way of doing that or defining that you then share with all the other parties that are going to look for those same patients. Because only by doing it that way, with those standards in mind, will you then be able to say that the person with MEN1 here is the same person with MEN1 here, and I will say that you have to be careful because diagnosis codes aren't really good oftentimes. Now, it depends on who diagnoses it. Let's say you had a specialist who has built their clinical practice around MEN. Well, guess what? They're probably going to be pretty good. If they have a cohort of patients, you're like, that's pretty good. But if you're picking it up from a place that never sees it, it might be the wrong code. It might not even be an MEN patient. It might have 2 out of 3, or it might have, and so you then have contaminated your registry with people that, because it didn't adhere to the same inclusion criteria or the same defining conditions, you've got a problem, and that's going to affect your research, because now you're going to have, let's say, 75% that are really truly MEN, and then 25% going, maybe not so much. And in each of those aspects of that patient, again, if you can't define it really well using a consistent set of concepts or data terms or terminologies, it's going to, again, affect some of that certainty about the results. And so that's really a challenge. But one way to do make it faster is, again, you have activated patients, and patients are oftentimes much more willing to share that information. So that gets you around one of the big complications, which is when you're working across institutions, this is not a data problem. It's a business and consent problem.
Yes.
Right? This is a big barrier, right? So then you say, well, institution A, can you give me all your patients? They're like, no.
Right.
And then you have to go through a data use agreement. But it turns out that patients who say, I want information to go to this person. Well, with 21st century cures, they now have the ability, usually it's, unfortunately, it's oftentimes still tethered to a patient portal, or but they can point and say, I want you to send data. I'm going to authenticate myself through your portal, and you're going to give data to this other person. So that's a really powerful thing that could potentially greatly reduce the friction for cross-institutional type of work like this. But it's still hard. Don't get me wrong. It's the data part is always really hard. So.
Yeah. And John, since you just graduated from boot camp, Genetic Alliance Registry boot camp, you're aware that the platform we're using, we've connected to 700,000 portals in the United States, and that data flow is while everybody sleeps, which is lovely. And as Abel said, it's people's right now, and which has been fabulous. And the standards are in place called FHIR, which maybe Abel will comment on, that allow that. And it's not perfect, and we don't get everything, but at least that's a big start. Yeah.
Actually, that was at the meeting again just before this. It is so exciting, the potential today, because, you know, for many of us who've worked in this space, we spent years of our time, lots of gray hair, working through legal agreements and getting to know all the lawyers and all the contractual arrangements. But with new developing standards, you do have this ability to both authenticate your identity in a very consistent fashion. You have APIs you can connect to these application program interfaces you can connect through directly to receive information. And then when it comes out, you can, again, using standards, you can use like a communication or transport standard like FHIR, which is FHIR, Fast Healthcare Interoperability Resources, that everyone loves in our world now. And you can get out data in a consistent format, at least. And in some cases, even, it's well mapped. That means that the FHIR extract comes out and it has a diagnosis code, and it says it's an ICD-10 code. It has a laboratory test, and it says, oh, it's a LOINC code, this LOINC code. And so you know with specificity that the content in that message is the things that you want, you know, and that's a really exciting place to be. And it democratizes a lot of this data movement. And again, groups like Genetic Alliance are way ahead on this one. I think this is the way we want to go. Like, we're trying to move that direction. But you know, like I said, things take time, and so we're still having to make that shift. And we're old and it's like hard. So, but we're going to try to get there. We're going to follow other people's leads that we're going to do, because you know, imitation is the best form of flattery. So we're just going to do that. So it's probably better. So.
Yeah. And I appreciate, Abel, that, you know, we have, you know, I've been able to do this for 26 years because I operate with great freedom. You know, my small PXE international organization or my bigger Genetic Alliance one, neither have the constraints of the enormous burden of the academic medical centers to follow certain, you know, pathways that are really grooves that our business models and mental models are so hard to change from the, you know, president of the university on down, and liability issues are incredible that we don't have. And, you know, we really see that you guys have such a challenge.
We do. I'll vouch for that. but again, I think that's the power of this approach you're taking. You know, like, the world is full of examples where somebody was incumbent and then somebody came along from the side, and you know, I think we're at that inflection point where we're going to see things different, and we'd much rather be part of that inflection point than sort of carrying on the same path.
Yeah, absolutely. What else, you guys? Abel's suggestion that your case studies, your problems, and even ongoing projects that are working, not working, have bumps, is really good for us here as a group to look at. If you don't mind sharing those, thanks, John, for doing that.
If while you're thinking about that, I can also introduce a new thing. So I'm going to summarize quickly. We talked a little bit about, you know, the missingness in the world of research of real patient information. This was about standards. Sharon also raised a question, I think, that had come up. I recognize how hard it is, like, to sometimes speak up into a group and you're like, oh man, I don't know if I want to say it, But so I'll just put a couple more feelers out here. I'm just gonna skip around a little bit. Sharon asked a question or wanted to clarify the difference between data visualization versus data analysis. And this is a map of Chicago, and I just want to share an example of that. Like, a visualization of data is really useful when you're starting out with a set of information, because it can tell you the shape of the data, the missingness of the data, you know, like the coverage, like a completeness of the data, all these types of like raw features about the set you're going to analyze. And the difference between a data visualization and analysis is that visualization stops. You just put the image up and then you look at it and you sort of like make some conclusion in your head and you ballpark it and gestalt it. Like, this is a map of diabetes in Chicago, and you say, well, pretty obvious. Looks like there's a bunch in the south side and some on the west side. The difference between that and analysis then takes and performs a statistical method or a test to see if it truly is different, you know, based on some parameters, some like scientific parameters. And so that same information, and you apply it through like a measure of whether or not one area is different than others. Clustering analysis tells you then, okay, very clearly there's high versus low areas in Chicago, and here's where the boundaries might be. So, you know, visualization is like just one part of it. It's an initial, and I always encourage all our students and our researchers, given a data set, don't just go right into analysis. First, start by visualizing it, because right there you can oftentimes say, oh man, I am missing 10 years of data in this middle donut hole. And then you go like, okay, stop, let's go back. Before do anything else, let's go and let's fix that. It's a really important part to think about. And this is just another example. Like, this is like I took it from I forget what newsletter or whatever. This is just a look, again, this is visualization of data. You're looking at on the top claims record versus EHR data, which is where we mostly operate in. And what this tells you really quickly is that there's a lot of information in EHR data that's probably deeper. It's got more types of information. You might get claims records. Analysis might be like something we're doing with the All of Us program, then where we're going to compare, like for a given person or a given set of people, how much additional information and what kind of information is available in EHRs that isn't available in claims. You know, so we're going to do a little bit more detailed work and then understand, like, so do claims record make our individual records more complete? Do we get 50% gain, 100% gain above what's just in the EHR? And so that's, again, the difference between like visualization, which this is, versus analysis, which again performs some test to figure out if that's really different statistically. So hopefully that gives you a sense, and if any questions related to, again, bias, standards, visualization versus analysis.
Mm-hmm. Yeah, and Abel, I think one of the things that's interesting here and is not so apparent to communities all the time is that this claims data layer, which now also includes other kinds of data, I would say is up here as well, and that is the stuff that Datavant and others are hawking on all of us, you know, that our trips to CVS or Walgreens and our grocery data, et cetera, is easy to aggregate in a sense because it's on electronic systems, but it doesn't tell the whole picture about us. So I think that your slide there is quite clear, and I'm glad to see you have something with even more granularity. Thank you.
This is, I think, I mean, like, I don't know what kind of, like, why I've always been suspicious. Maybe I'm a suspicious person, but like that we're missing a bunch of stuff, you know. And you know, I spent so much of my career working in that blue space with all those like clinical data in that middle T there. But you know, there's all this other exciting work out there. I do believe that getting the full picture oftentimes does mean crossing sectors. You know, we got some exciting projects here in Chicago where we've been able to link you know, the blue stuff, the clinical records, with like a homeless registry and their knowledge about whether people have been given stable housing or not. And that's been very illustrative. You know, we published some papers about that recently. Similarly with schools, you know, linking across health records to school systems, also very interesting insights. And even simple things, you know, like I would argue that, like, if you look at death records here, remarkably bad, like in this country. Even like death certificate data, I don't know if this is something that you guys have come across or not, but death certificate data in this country is, you ask any clinician, is that real? And they're like, no, because a lot of times the people that fill out death certificates aren't the person that took care of the patient, or they don't know all the conditions, and we're trained to fill them out a certain way. And so for something as important as death, we don't do a great job of really capturing the reasons why people die, you know. And so that's another gap. So even though this map shows this whole world of all these data elements, there's a lot of work to be done to be able to do it well and get across these different domains, even for something as simple as death versus seemingly as simple as death.
Yeah. Yeah. And I think about too, you have, for example, Facebook postings and tweets and so forth that, again, and we're watching the Congress grill Facebook at this point, that there's a lot of data there and a lot is shared without the protections that we're now seeing emerge in certain jurisdictions like Europe and like California and so forth. And at the same time, there's a lot of value there in the sense that people continue to connect there. I've talked to my PXE International Facebook group, 2,000 of the 4,000 people in the world with PXE, and said, you know, if your data is being sold, if it's being used maliciously, if it's, you know, criminal activities happening with it, do you want to stay here and continue to converse? And they all said, yes, we do. It's like convenience is more important than, you know, some of these other things that we who are working in data feel we should be protecting people for. And so some kind of marriage between these things are going to be really important, that we do start to move some of these more social posts to structured data, and at the same time allow people to have the conversations they need to have.
And I think it's going to be person mediated, you know, for all the reasons I think you mentioned earlier. There's these grooves that exist out there that are hard to break, you know, and so, but there's a person autonomy component to this that, you know, as long as that's empowered, what can break this. Not for everybody, because, you know, not everybody has the tools or to be able to do this on their own, you know, and so you do need to have advocacy groups that show up willing to educate folks and prepare them and provide them with the right set of tools and constructs that they can be empowered. You know, that's it's hard to do it on your own, but people helping other people goes a lot further. So I think that's again a power of these networks that you're building.
Abel, a comment from somebody directly to me that'll editorialize a little bit. So the question is about the large EMR, EHR aggregating companies, so, you know, Cerner and Epic and so forth,
Sure.
and their approach to rare disease communities to get the patients to consent to populate specific data sets. And, you know, you and I both had some experience with them, and I did on the Obama HIT Standards Committee, knowing that their business model, mental models are very different, and that now people have the right to do that with or without the permission of the EHR company. So what is your experience in this realm?
Well, I mean, it's obviously been, you can't reconcile, and I don't want to blame people for this. I mean, every organization has its own mission, and it's, you know, wrought from whether it be the founder or a business priority, an existential priority, that is not always going to align with the individual's priorities. And I think we have to be very open-eyed about that as to what the mission and drivers of an organization are versus the individual. Now, again, I think this is where policy can be very, very powerful, as we're seeing now, and where policies can disrupt that. You can shift some of those what oftentimes is a power imbalance. I think that's a real potential here. And I do think I see that happening now. I think before it was sort of really difficult, you know, but I do see that the shift is happening. And but again, it's kind of like you know, companies that will give you things knowing that you're not going to like have the wherewithal to send something back to them, you know, like you know, you do need to have oftentimes, again, these groups that will advocate and allow people, make it easier for people to be able to have that capacity to own their own data or to do things with their own data. But it is possible today with help, oftentimes. So in healthcare, in primary care, we've had this model for many years of practice facilitation, where we help primary care providers do better with certain types of quality measures. There's community health workers that do that in communities. And then there's, like I said, patient-powered sort of groups or patient empowerment groups that do the same thing. I think no one does it on their own, you know, like it's rare. And so you just need to have these different, like, whatever you call them, advocacies, facilitators, you know, that are going to be there to lend a hand out to you. Otherwise, it's just the momentum and the inertia rather is too high oftentimes to move, especially if you're not feeling well or you're, you know, stressed or have the resources aren't there. How are you going to do it? You know, I think that's where you know, we and funders can do better. But
Yeah, funders, it would be lovely to see a funder arise that got this. You know, I keep having hope with certainly NIH and then Picori and then Chan Zuckerberg and so forth. But it's so interesting to me, and I, you know, having been on the inside of a lot of these as an advisor, and you have been as well, Abel, that there's a kind of default to the same old structures because
right.
Start out saying we're going to change how things are done, and then they just find the roadblocks so immense that they don't want to take the risks. And one of the things I advocate for is, you know, the members of the communities of the people you see on the screen and all the thousands that belong to Genetic Alliance are suffering every single day. They're dying, and we're not taking risks to measure it with their risk. And we really have to find a funder, I think, that could be that bold, is to say we're willing to risk that this may not work, and we just have to go and shoot for it with people like you, Abel, and, you know, again, lots of the people I worked with at PCORNet that are ready, willing, and able to do this.
It's hard, you know. Sure, and I always welcome. I like hearing your opinion on these things, because I think that the financial drivers are, at the end of the day, it's so much of it's financial. You know, like whether you and again, I don't fault people, because you want to maintain your shop, you want to keep people employed. It's hard times, and so so if there is a way of creating like a win-win or a business prospect that makes it, then it's easier. But even with foundations, they're not limitless. You know, they have competing priorities, and so you can't. I mean, I have a hard time faulting them. I haven't, and maybe you guys know better. Like, I haven't been able to figure out what is the angle that makes it financially viable or self-sustaining, that keeps these things moving. Because unfortunately, in this country, I think dollars win the day. You know, so
yeah.
So I don't know. Have you had any thoughts or ideas about how that might go forward?
You know, I keep bringing in and looking at other industries, because I think our solution is going to come from somewhere else and not within this, I like to say, highly regulated cottage industry that is our healthcare in the U.S. and the globe, really. And I look at things like the other places where this kind of disruption occurred and consumers became the central focus finally. And there are things like the music industry that we know about with Napster and iTunes. Things like the ride sharing industry, and, you know, the force of the taxi cab drivers or the music recording companies was strong, but the consumers were so numerous and they just kept making hacks that finally the industry had a cave to the hack, and now the hack is standard. So, you know, I think it's going to be so much harder in healthcare, because we all don't. It's not the same as hailing a taxi, in the sense that this is everything on the screen is black box to us for the most part. Like,
Right.
sure, we have legal access to a lot of this now, but to get to it, then we can't read it, we can't see it, we don't know one from another, we don't know the person we're sitting next to on the metro also has the same problem we have.
Right.
Yeah, so I don't know. I think it's going to have to come from, and you know, and again, I'm going to say, I'm going to contradict myself in a way. You know, the Amazons and the Berkshire Hathaways tried this and are trying.
Yeah.
I'm not going to say they're done, but they're having a heck of a time. Google tried it and couldn't
Right.
do it. You
Right.
know, so
Multiple times.
yeah, yeah,
It's just, it's, yeah, I haven't, I mean, we certainly, I do think that there's a, I don't know what you call it, like an ionization, the commodification of people's data that could be more equitably distributed. Like, but it involves a little bit of technical wizardry, and some people are doing it, I think, to be able to capture the volume and the value of transactions. And it's no, I think in some ways it could be like a fair trade coffee model where, you know, the value chain is propagated from start to finish.
Yep.
But there's definitely incumbents in there right now that would not want to share that value chain. So
yeah, yeah.
it's a little tricky, but
Yeah, yeah, and I think about too, you know, we've treated data like gold or oil. We've treated it in the kind of commodities that are scarce model rather than like air or gravity, you know, like there's plenty of it, more than enough to go around. It's not where we want to build our model. We want to build it on the downstream stuff. My one successful kind of image of this is I chaired the first PubMed Central board. And that was the goal, obviously, was to put all these papers in PubMed Central and have them freely available to the public. And man, I got everything from vicious emails that were really malevolent from, you know, the major publishers to trying to wine and dine me. And I turned down all the dinner invitations I got from them because they were so scared that they would go out of business if we had open access. And you know what we know today is, yeah, we still have a bunch of articles that are behind firewalls, but we also have a reasonable open access kind of success rate. And the journal editors and publishers, I think, figured out their value was not in publishing the article. Their value is in how do they package it? What else do they offer? You know, the downstream benefits. And I think we're going to have to see the same thing happen here, where even the academic medical centers start to say, oh, my value is not locking up the data. My value is I have cool scientists who know what to do with these data, and that's what I'm going to compete on, not the amount of data or the amount of people with XYZ disease within my system. You know, I think we're going to have to see that kind of shift.
yeah. Yeah, I like that a lot, and it's so much so that we actually have been embracing this idea of creating like libraries of data. We call it a health data gymnasium that's available to students from any walk of life, you know, and we're trying to organize these collections, and I think that's that because, you know, it doesn't serve anybody's purpose. Like I said, firewalling it. Like public libraries exist, you know, like
Yeah.
last check. So
Yep.
I can walk in there for free. But
Yep.
similarly, I think with the newer data economy, you know, having libraries of data that anybody can access, I think are equally empowering. So,
Yeah.
you know, I think that's clearly a future. And again, that is maybe a place where, you know, patient-driven registries are going to be leaders. So
Yes. Yeah.
I think that's something that's exciting. And we
And
think actually maybe something that Sharon we'd love to talk to you about too, because like we've been building a framework for how to make this available responsibly, safely, and
yeah.
But you know, some of these unique sets, what the registry would get would be students willing to roll up their sleeves and just go to
Yeah.
work, you know, like that's always hard too, finding technical resources to really. I talk
Right.
about, you know, visualization versus analysis. Turns out both are hard to staff.
Yes. Yes. Yeah. Yeah. And Abel. So we have in this this project that's now 26 years old called the Promise for Engaging Everyone Responsibly, a registry system. We have cracked that nut in a way, in the sense that we have many advocacy organizations doing this work together, so that the back end database, the workspace, is seamless across all of these diseases. So we're not siloing the disease to start with, and that anybody with a IRB approved And we have our own IRB, so we make sure that it takes 48 hours and $300 to go through our IRB. That we can approve these, and then those researchers, students, I say smart Girl Scouts, it doesn't matter, can come to these data sets and do the work that these communities need and want. So we as communities are great at getting people to participate. And we have EHR, we have genomic data, we have GVCF files. I mean, it's pretty robust. 700,000 EHR portals, and then every single validated instrument in the world is in our library so that groups can use it or write a bespoke survey. Anyway, all that data. And then in the workbench, we have Tableau, we have R, we have SAS, we have, Jupyter Notebook, Hail, and students can come and for a very low nonprofit rate, like an iTunes model, can set up a workbench and do research. And this is all covered by GDPR and CCPA and the new Virginia law and so on. And you're right that the kind of challenges are, you have the challenge around, can we get the communities together so that we can get these data liberated in a sense for your gymnasium? I love the idea. And then on our side, can we get students and people who want to work with data to practice on our data, because we have so much of it and really needs people.
We've got that part. So
good.
Like, sign us up. We're happy to have pointers directly to your portal, and we can bring the people on that. I just had a call before this with IIT, which has a lot of very local sort of students, and there's reams of students who would love to learn more about this. So. Yeah, cool. And again, it's a matter of us figuring out how do we communicate across stakeholder groups and know about each other. And to broaden that, Genetic Alliance has broadened all of our work to not just be disease advocacy organizations, but we're working in communities now, faith communities, fracking communities, Black Lives Matters communities, because it doesn't matter what your affinity is. It really matters that you get the questions you have answered. That's right.
Cool.
That's right.
So we are almost at the top of the hour. Any last question from the participants, or Abel, a last word?
I'll wait for questions. I mean, only last word I would say is thank you, Sharon. I look forward to this. I was also going to commiserate with you someday about this whole thing, but I think that the work you guys are doing is so important, and it is where the puck is going. And so if there's ways that I can help and ways that we can work together, we would love that. And yeah, so doors open.
Cool. Wonderful. Okay. Any last words from participants? All right. Everybody have a good day. And Abel, thank you so much for doing this with us.
Yeah, happy to.
Okay.
Thanks.
Thanks. Bye-bye.